Great. Thank you so much, Michelle, and thank you to all of you for tuning in tonight for an evening of hypertrophic cardiomyopathy. Here are my disclosures, none of which are particularly relevant for this session. And I'll really be talking about the diagnostic journey for patients with hypertrophic cardiomyopathy, focusing a bit on imaging and how genetics may play a role, and also looking forward into the future to see how these insights might help us with future care of our patients. So when thinking about hypertrophic cardiomyopathy, the standard clinical diagnosis is made when you identify unexplained left ventricular hypertrophy in one of your patients. So that's increased left ventricular wall thickness that's not explained by increased pressure overload, such as from hypertension or aortic stenosis, or from storage or infiltrative processes. So the pathologic hallmarks of hypertrophic cardiomyopathy are myocyte disarray and increased myocardial fibrosis. Most patients have near normal longevity, but there are very serious outcomes in many of our patients, including sudden death and an increased risk for heart failure. The overall prevalence in the general adult population is 1 in 500, and that predicts about 600,000 cases in the United States, many of whom have not yet been diagnosed. So by studying large families with hypertrophic cardiomyopathy and comparing the DNA of those who had disease to those who did not, investigators led by John and Christine Seidman back in the late 1980s and 1990s determined that pathogenic variants in genes encoding the sarcomere apparatus could cause HCM. And so genetic testing is commercially available now, and when applied to all comers with a clinical diagnosis of HCM, about 30% of the times we'll find a pathogenic or likely pathogenic variant in a sarcomere gene that's attributable to causing HCM. But if there's a family history of HCM and therefore a higher a priori likelihood of genetic disease, over 60% of the time we'll have positive genetic testing. And again, variants in the sarcomere genes are the most definitively and most frequently associated with hypertrophic cardiomyopathy. And of the sarcomere genes, variants in myosin binding protein C and in myosin heavy chain account for over 80% of HCM, in which the underlying mutation has been defined. And so with genetic testing in HCM, more is not necessarily better. So when we've increased to bigger panel sizes beyond the 8 core sarcomere genes, or even to looking at the whole genome, there hasn't been a clinically actionable increase in the yield of genetic testing. We'll get a lot more variants of uncertain significance, as we'll talk about in a little bit, but not necessarily definitive results. Cardiac imaging is also key in diagnosing hypertrophic cardiomyopathy and plays a major role in identifying the variation in cardiac morphology, the degree of hypertrophy, and the amount of fibrosis seen. And we really want to use multi-modality imaging with echo and MRI as our mainstays. And here you can see the MRI features that we look for in terms of increased late gadolinium enhancement, suggesting dense replacement fibrosis. And this is particularly helpful in looking at some of the variants of hypertrophic cardiomyopathy, like apical variant HCM. With standard echo imaging, you can see sometimes our endocardial definition is not great. And it's hard to make out the apical hypertrophy here. It's kind of hinted at, but it's hard to make out definitively. If we apply echocardiographic contrast, it really brings out that apical hypertrophy. And again, with cardiac MRI and increased definition of the endocardial borders, we can see the morphology even better. And then even old-time methods like EKGs can give a hint because you will typically see these deep diffuse T-wave inversions across most leads in patients with apical HCM. So these multimodality approaches are synergistic. We rely on echo best to try to characterize LV systolic function and diastolic function, and also to look for pathophysiologic features, particularly determining whether obstruction is present or absent. And so the type of obstruction that we're, interested in is looking at systolic anterior motion of the mitral valve and outflow tract obstruction. And so you can see that here on the two-dimensional echo, where there's systolic anterior motion of the mitral apparatus here in 2D and also on the M mode. And that leads to outflow tract obstruction and posteriorly directed mitral regurgitation. And then with echo, we can also quantify the amount of outflow tract obstruction that's present. And you want to make sure that your sonographer starts at the apex and then moves the sample volume closer and closer to the outflow tract to figure out where that obstruction is happening. Is it in the mid cavity caused by systolic cavity obliteration, or is it really in the outflow tract caused by systolic anterior motion? We think that that's outflow tract obstruction is probably physiologically and clinically most significant. We want to check it at rest, and also with provocative maneuvers, because sometimes resting gradients can be relatively modest. But if you have provocative maneuvers, typically in the echo lab, we'll use a Valsalva maneuver. In the clinic, in the exam room, I like to have people stand from a squatted position, and that can bring out latent obstruction. And make sure that you're accurately characterizing somebody as obstructive or non-obstructive. Of course, the best way to sort that out is with physiologic stress, such as exercise. And then the morphologic features can also tie into the genetic background, as patients with the more typical asymmetric septal hypertrophy or reverse septal curvature hypertrophy are most likely to have sarcomeric HCM or have a pathogenic or likely pathogenic variant in a sarcomere gene. So we see this in about 30 to 40% of patients with HCM, and again, that's most likely to be sarcomeric. You can sometimes see sigmoidal septum or that discrete upper septal thickening. That's quite a non-specific feature. We oftentimes see in older patients, particularly older women with a touch hypertension. Again, that's non-specific and pretty unlikely to be associated with true sarcomeric HCM. Apical variant HCM, we see in about 10% of the population in the US. And again, pretty unlikely to be associated with sarcomeric HCM. I would say that this estimate is even lower in more contemporary cohorts, probably less than 10 or 15% sarcomeric HCM. And then if you have neutral or concentric HCM, it's a little bit more of a coin toss, whether it's sarcomeric or not. Moving on, I'm going to focus a little bit more on genetic testing. That tends to be something that people may not be as familiar with. So we'll go through, why perform genetic testing and some of the specifics around getting genetic testing and interpreting it. So genetic testing can be super helpful in helping us define the etiology of disease. This gives us the potential to clarify ambiguous diagnoses, because distinct diseases may share a common, low resolution phenotype, such as left ventricular hypertrophy or HFpEF even, but have different underlying mechanisms, which are important in terms of their clinical course, the treatments that you might want to apply, and the implications for the family. So, for example, all of these individuals have superficially pretty similar looking cardiac morphology on high resolution cardiac magnetic resonance imaging. But even with good imaging, we don't know precisely what disease these people have. When we did genetic testing in this first case, this was a 36-year-old woman that ended up having a myosin heavy chain mutation and identifying her as having sarcomeric HCM. This is a 40-year-old woman that had Noonan syndrome and really with features that were really quite restricted to her heart, not with the typical facial features or other syndromic features. She had a PTPN11 mutation. That's how we sorted that out. This is a 43-year-old gentleman that was found to have a mutation in the alpha-galactosidase A gene, indicating he had Fabry disease, and he was sent on for enzyme replacement therapy. This is a 70-year-old gentleman that had cardiac amyloidosis. So genetic testing indicated that he did not have a mutation in the transthyretin gene. So this indicates that he has wild type rather than familial amyloidosis, because it was determined that he had TTR amyloidosis by both pyrophosphate imaging and by biopsy. So we can reassure him that there are no implications for his family, and then move him on to all the great novel therapies that are being used now for cardiac amyloidosis. So it's important to know what disease you're treating. And hopefully in the future, we can move more towards a precise, personalized molecular approach to diagnosing diseases with cardiac hypertrophy. And it also matters clinically because genetic background can provide some important prognostic information. So this is data that was gathered in a large multi-center registry study, this SHARE registry, where we looked at several thousand patients with hypertrophic cardiomyopathy who had had genetic testing done and looked at their rate of having the overall composite outcome, which is a composite of death, need for transplant or left ventricular assist device placement, cardiac arrest, sudden death, appropriate ICD discharge, progressing to NYHA class 3 to 4 symptoms, having atrial fibrillation or stroke. And you can see that those individuals that had sarcomeric HCM here in the green curve had earlier onset and more prevalent outcomes than those that had non-sarcomeric HCM in red. And that holds true not just for the composite outcome, but for all individual components of the composite outcome, with hazard ratios ranging from about 2 to almost 5, highest for the need for transplant or VAD in sarcomeric HCM. So again, we can move on to thinking about performing genetic testing to help us define the genetic etiology and also like have some insight into prognosis and treatment in that regard. And also, genetic testing can be extremely useful in guiding family management. And this is probably the most practical use of genetic testing in the current day, because it can allow us to definitively identify at-risk relatives who are at risk for disease development. So right now we say if you are related to an individual with HCM, particularly if you're a first-degree relative, you are yourself at risk for developing HCM, and you should be followed longitudinally to see if you're developing any features of disease. But we know that, roughly only half of the family is truly at risk because it's an autosomal dominant disease. And the other half did not inherit the pathogenic variant and aren't at risk. So with genetic testing, we can identify those who did inherit the variant and are at risk for developing disease from those who did not inherit the variant and are not at risk and can be dismissed from longitudinal screening. And so in this way, you want to think about genetic testing as testing the family, not just the individual. All right, so where to start? Well, even just getting a good family history and generating a comprehensive pedigree is a great way to dive into family history. And your first foray into genetic testing. And so this comprehensive family history and being able to visualize it can help determine if there's familial disease and help you understand what the mode of inheritance might be. So this sample pedigree is showing an example of autosomal dominant inheritance, where there's roughly half the family members are affected, and there's evidence of relatively even distribution amongst males and females. And you also can try to identify the ideal genetic testing proband in the family. So who in the family should go forward first for diagnostic genetic testing? And you want the person with the most severe and the most clear-cut diagnosis of HCM. And you can also identify the at-risk relatives who need phenotypic evaluation and who would benefit from determining the genetic etiology of disease if you display everything in this manner. So there are two different types of genetic testing. The first is diagnostic testing, in which you use a broad panel to try to identify the genetic etiology in a patient with known or suspected inherited cardiovascular disease like HCM. And so, again, this is accomplished with multi-gene panels that are tailored to contain the genes that are implicated in causing specific conditions, like HCM, dilated cardiomyopathy, arrhythmogenic cardiomyopathy, or long QT syndrome. And the sequence of those genes will be simultaneously interrogated. And then there's also predictive genetic testing, which is used to determine if a family has inherited a pathogenic variant that was identified in the proband that underwent diagnostic testing. And this will help determine that relative's risk of developing disease. So it's very focused to look for the presence or absence of that specific variant. And it's also called known variant testing. And one of the most complicated arenas around genetic testing is not like our usual laboratory testing, where you send cholesterol panel and you get the cholesterol results. That's very easy to interpret. Genetic testing is different because it's probabilistic. rather than deterministic, and the genetic testing results will give you what the laboratory thinks is the likelihood of any identified DNA variant being able to cause disease. So sometimes no variant is identified, that's called as negative genetic testing. But sometimes we only see benign or likely benign variants because they're very frequent in the general population, not conserved. So those variants that might be identified in genes of interest would also be considered negative because they're unlikely to be able to cause disease. And positive genetic testing is when we find either variants that are thought to be potentially capable of causing disease or clearly capable of being able to cause disease. So those are classified as likely pathogenic or pathogenic. And the laboratories apply standardized criteria to sort out, the probability of them being disease-causing or pathogenic. And so these variants have to be very rare in the general population, much more rare than the prevalence of disease. They ideally have to have some evidence of segregating appropriately in affected families. There should be some type of clinical or functional data suggesting that they are important, or they need to be de novo, meaning just arising in the affected individual themselves, not with unaffected parents. And so if it meets all the criteria for being classified as pathogenic, then that's a variant that we can very confidently use for predictive testing in relatives. If there's not quite that degree of certainty and it's classified as likely pathogenic, we can use it for predictive testing, but we might want to use it a bit cautiously. And so instead of completely dismissing patients from longitudinal follow-up, maybe making sure that relatives know that they should come back if there's any change in their clinical condition. And then in the middle, we have the dreaded variant of unknown or uncertain significance. This is when a variant is identified in a gene of interest, but it's unclear whether it on its own can cause disease or not, because there's either very limited or conflicting data about its clinical significance. And so this is an ambiguous, inconclusive result. The variant is not a reliable marker of disease risk and therefore cannot be used for predictive testing and to determine the risk in relatives. If you have a big family, you can use the family actually to try to understand the variant a little bit better. And if it segregates or if it is associated with disease in all of the affected family members and that no affected family member does not carry the variant, then that can give you more confidence that this variant is clinically significant. But in general, there are inconclusive results, and we hope that we'll become smarter in the future and be able to push them into a more actionable field as either being benign or pathogenic. And the other tricky thing about genetic testing is that the variants can be reclassified over time if new evidence develops or if new rules are developed. So what provided in a laboratory report at one point may not always be the case forever. So it's important to periodically check with the laboratory or check with some of the publicly available databases to see if the variant classification as initially reported still stands. So it's a lot to do with genetic testing. Sometimes it can be a little bit overwhelming, and it's important to know that you can always phone a friend and send patients to genetic counselors or groups with specific expertise in cardiovascular genetics for assistance with this. And so let's take a look at a case to understand how genetic testing can be used. You see that our proband is in the middle. This is the first individual in the family to be diagnosed with HCM. He's a 32-year-old gentleman, generally in good health, but was noticing more exertional dyspnea when working out at the gym. His PCP heard a murmur and sent him for an echo, which identified HCM. And he also got the family history that the dad died of what was called an MI when he was 38 years old, but he was, otherwise quite healthy. He was a lawyer arguing a case in court and collapsed and couldn't be resuscitated. And then his brother, so that our patient's paternal uncle, also died in a car crash at age 30, but it was a little bit suspicious in that it was a single car accident where he drove his car off the road and into a tree. And then he tells us that his brother also has been told that he has athlete's heart at age 26. He doesn't have other details, but did share that his brother wasn't really that much of an athlete, more of a weekend warrior. So should genetic testing be performed? If so, how and why? All right, excellent. So he does have a suspicious family history with issues going on that kind of raise a question mark in dad, paternal uncle, and brother. So all of these individuals are at risk for disease because they're related to somebody that has HCM. And so we want to think about family screening. So that is typically started in first degree relatives and then expanding or cascading out as we identify more people with HCM in the family. And the goal is to identify relatives with unrecognized HCM so we can follow them appropriately and to follow those at risk for disease development for the emergence of HCM. And overall, we want to minimize complications and excess risk for sudden death, people in families with HCM. This is typically accomplished with a physical exam, an echo, and an EKG. And because the penetrance of HCM is age dependent, meaning it's not typically present in babies, it's very rarely seen. It's rare, but less rare in children. We typically start seeing it manifest in late adolescence and early adulthood. So because of this age dependent penetrance, serial screening is required. So that's the frequency and the timing of screening is typically based on the age of the relative and the age of the proband. So we typically recommend screening children and adolescents at the time of family diagnosis, particularly if there's a family history of early onset HCM or known genetic disease, and you want to assess them every year or two. And then in all other adolescents, you want to assess at some time before puberty, and then every 1 to 3 years thereafter. In adults, we want to assess at the time of family diagnosis, and then every 3 to 5 years. All right, so our patient is wondering, how can he be more certain about what will happen to his children? So this is where we talked about genetic testing. And again, we have a sense that there's a family history, and so there might be a reasonably good chance that we'll find actionable genetic testing results. So indeed, pathogenic variant in myosin heavy chain was identified in him. So this suggests that this was familial disease, and his first-degree relatives had predictive genetic testing performed, and his sister was found to not carry the variant, whereas his brother did carry the variant, and one of his 2 kids was also a variant carrier, although completely healthy at that time. So again, this helps to clarify some of the ambiguous diagnoses in the family, suggesting that both of his father and his uncle likely had HCM-related sudden death, and that his brother does not have athlete's heart, but likely HCM. And because of this family history of sudden death, the other 2 individuals known to have it, both he and his brother opted to undergo primary prevention ICD placement. And then we can also focus our longitudinal family follow-up from the 7 individuals who are initially possibly at risk to just the one that's definitively at risk, that is his daughter that carries the variant, but at age 6 appears to be healthy and unaffected. And so those family members that are genotype negative or do not carry the variant can be reassured that they are not at risk for developing HCM or related complications. And also their offspring are not at risk. So we don't even have to test his sister's kids because we know that they can't inherit the variant because their mom does not have it. And longitudinal follow-up is not required, although we would always want to follow up if there's clinical change. For the genotype positive family members, those individuals are at risk for developing HCM and should undergo longitudinal follow-up. And there's a 50% risk of that individual transmitting the genetic risk to each of their offspring. That's important to understand that genetics is not necessarily destiny. So having a pathogenic variant means that you're at increased risk for developing HCM, but it's not a guarantee that disease will develop. And we also can't predict when or how severe disease may be, but it's a good risk marker for those in the family that are at high risk for disease development. And so finally, genetic testing can be used in the research setting to help us develop the knowledge that we need to change our clinical paradigms. we have the remarkable ability to identify individuals that are at risk for disease development well before the onset of clinical disease. So can we use that knowledge to treat in a more proactive manner? And can we actually use knowledge of understanding the molecular basis of disease to develop treatment that is designed to change natural history rather than simply palliate symptoms? So some of the take-home points on genetic testing: making a 3-generation pedigree is a great and straightforward screening tool to look for genetic disease. Genetic testing panels are used for monogenic diseases like HCM. So there, although we know that most of the money is going to be in those 8 sarcomere genes, the panels that we use now have usually about 30 to 50 genes on them. A positive result does not guarantee clinical disease will develop, because again, there's variable penetrance and expressivity, how severe disease will be. And also, negative results do not exclude a genetic etiology. They let us know that it's not in one of our big players, but it could still be genetics at play in a monogenic manner in genes that we haven't yet discovered that can cause HCM, or also in a polygenic manner where the heritability is a little bit lower. And then these ambiguous results, these variants of unknown significance, leave the provider and the patient a bit in limbo. And hopefully, again, as knowledge accumulates, we'll be able to get rid of that category altogether. And then genetic testing may help clarify diagnosis and improve family management by identifying and focusing longitudinal follow-up on those that are truly at risk. All right. And then now I want to move a little bit into the future and think about how we might be able to put this all together and develop new and improved strategies for taking care of our patients and families. And so here's one schema of thinking about the landscape of HCM. So we can think about the stage being set if a sarcomere variant is inherited or present. Research has shown that there are primary effects of these variants. So even before left ventricular hypertrophy is present, we can find subtle abnormalities in terms of hypercontractility, diastolic dysfunction, impaired relaxation specifically. There's a predisposition to developing fibrosis, and there can be impaired myocardial energetics. Even in this early stage, call these individuals with subclinical HCM or genotype positive, LVH negative. So before left ventricular wall thickness increases, we can sometimes see these abnormalities. And then with the influence of age, other genetic modifiers, lifestyle or comorbidities, the additional effects of HCM can be revealed, and clinically overt disease can be established with the adverse remodeling and the development of ventricular hypertrophy. And this is when we see adverse outcomes and symptoms. And so if there's symptoms related to outflow tract obstruction, we'll use beta blockers, calcium channel blockers, disopyramide, or think about invasive septal reduction therapy. If there are ventricular arrhythmias, or we will try to risk stratify individuals for malignant ventricular arrhythmias and offer primary prevention ICD appropriately. We'll be on the lookout for AFib, because individuals with HCM are at higher risk for AFib and higher risk for thromboembolic complications. So anticoagulation and rate and rhythm control strategies are needed. And then about 8% of patients with HCM will have advanced remodeling and develop left ventricular systolic dysfunction. And in the context of HCM, that's an LVE of less than 50%. Or other patients can have advanced remodeling and have severe restrictive physiology that's refractory to medical management. And so in those individuals, if there's systolic dysfunction, we use guideline-directed medical therapy for HFrEF. And then sometimes we have to think about transplant if we can't improve things otherwise. So our current treatment targets symptoms, which is effective for many, but not all patients. It starts relatively late in disease evolution. Previously, there have not been disease-specific or disease-modifying therapies, and there's been very sparse evidence regarding efficacy, with very few and almost no appropriately sized randomized clinical trials performed in hypertrophic cardiomyopathy. So a better understanding of disease mechanism by characterizing sarcomeric HCM in the lab and in patients has really allowed us to identify new targets for therapy. So as you recall, normally there's very carefully regulated actin-myosin interaction through the chemomechanical cycle that leads to normal contractility and effective relaxation. So there's very highly orchestrated attachment and detachment of the myosin heads from the actin thin filament. So one model of HCM pathophysiology is that there are too many actin-myosin cross bridges engaged. So too many oars in the water trying to row the boat, too little of the super relaxed state of myosin where the heads are disengaged completely from the thin filament. And this leads to hypercontractility, impaired relaxation, and altered myocardial energetics that are key features of HCM pathophysiology. And then there have recently been the development of a new class of medications called cardiac myosin inhibitors, of which mavacamten was the first-in-class agent. So these are targeted allosteric inhibitors of cardiac myosin. Mavacamten specifically helps to stabilize a super relaxed state of myosin, and that helps to reduce the number of actin-myosin cross bridges. So when you give a person or give a sarcomere mavacamten or cardiac myosin inhibitors, this helps to attenuate hypercontractility, improve compliance, and improve energetics. And so mavacamten has progressed through phase 3 clinical trials. This was the Explorer HCM trial published in 2020, looked at 251 patients with symptomatic obstructive HCM that were randomized to receive either mavacamten or placebo for 30 weeks. So because patients with HCM, luckily have a relatively low event rate of hard clinical events or event rate that's spread throughout their lifetime, looking at typical standard clinical outcomes is not particularly feasible in examining HCM clinical trials. So most of the trials that have been conducted and are ongoing are what we call feel and function trials. Can they help patients feel better, improve symptom burden, and can they help them function better by increasing metrics of exercise capacity? The Explorer trial looked at a combination of both of these. Was there an improvement in peak VO2 and NYHA class, or was there a more marked improvement in peak VO2 with no worsening of NYHA class? So mavacamten appeared to be beneficial, and there was significant increase in the number of patients on mavacamten versus placebo that achieved this primary endpoint. And there was also a signal demonstration of benefit in a more rigorous endpoint, looking at both a marked improvement in peak VO2 and one class improvement in NYHA class. And again, mavacamten demonstrated significant benefit. In secondary and ancillary studies, there was also a decrease in NT-proBNP, improvement in KCCQ, that's the Kansas City Cardiomyopathy Questionnaire score, looking at health-related quality of life. There was a decrease in LV mass, a decrease in left atrial volume, and improvement in E prime velocity, and a decrease in E over E prime ratio, so improvement in diastolic parameters. More recently, the Valor HCM trial was performed in patients with more highly symptomatic obstruction that were considering septal reduction therapy. And in that trial, mavacamten provided adequate clinical improvement for patients to be able to defer invasive septal reduction therapy. And there's a second cardiac myosin inhibitor racing its way through clinical trials now. It's called aficamten. And the phase 3 clinical trial of aficamten in symptomatic obstructive HCM should be reporting out in December. So hold on to your hats for that one. And aficamten is also being used in a head-to-head comparison versus metoprolol. And so looking even beyond this, can we so it's great that we have things that seem like they improve symptom burden and improve functional capacity in HCM with a more bespoke disease-specific therapy. But can we actually stop the clock? Can we prevent disease progression? So this is a very challenging area. We need to know how to treat. Can we identify and target key pathways? We need to know whom to treat. We can target our subclinical HCM individuals, but we know that disease may be mild or non-penetrant. And in those, if we could figure out that that was the fate of that individual, we wouldn't want to necessarily treat them with aggressive therapy. We want to target those at highest risk. And we also need to understand if there are genotype-specific differences in treatment response. Not all genes may behave the same. And we need to know when to treat. Are we going to need lifelong therapy for genetic disease? And, a huge challenge is, trying to figure out how can we monitor treatment. how can we tell that we've made a healthy person a little bit better? Can we figure out what subtle disease progression markers are, and can we detect subtle treatment response? So there was mouse clinical trials aimed to do just that, looking at the earliest pathways that are activated in mice that carry HCM mutations. It looked like there was profibrotic gene expression that was upregulated, and pathways centered around activation of TGF-beta seemed to be a very early indication of sarcomere variant in these mice. So studies were done looking to see if TGF-beta activation was inhibited either by using TGF-beta neutralizing antibodies or by using losartan. Could those treatments improve the fate of these mice? And indeed, there seemed to be attenuation of phenotype progression in those mice that were treated with those agents versus untreated mice. We can see that there's more hypertrophy and there's a lot more fibrosis in these blue patches. It's important to know that these were clinical trials that were done starting treatment very early, and that seemed to be when it was most beneficial. So it was started when mice were young and before they developed LVH. So can we take this into the clinical arena? So this is where we designed the VANISH trial, which is a phase 2 clinical trial trying to see if we could attenuate disease development in early sarcomeric HCM. And so we knew that it was going to be very hard to try to show a treatment benefit in these reasonably healthy young individuals. And so we weren't sure what a single outcome metric might be. So instead of trying to pick the single right metric or the single best metric, we tried to identify moderate effects across 9 different metrics of cardiac structure and function, which you can see here. So these are metrics that we know can be abnormal in the earliest stages of disease. Could there be overall improvement in some or the majority of these metrics? And so in this way, we're trying to interrogate disease biology. Can we affect improved remodeling, not our traditional clinical outcomes or even feel and function outcomes? So we wanted to standardize these changes in effect size individually, and then as a composite Z-score. So the composite Z-score was constructed as an increase in the Z-score would reflect relative improvement, and a decrease in the Z-score would reflect relative worsening. So that's what the primary outcome was. This is the schema for the VANISH trial. Again, we were trying to attenuate disease evolution in early sarcomeric HCM. So all these individuals had to have sarcomeric HCM with a pathogenic or likely pathogenic variant. And we wanted to start relatively early in disease. So individuals were 8 to actually 45 years old. We wanted them to have essentially no symptoms, so NYHA class 1 or 2, and no obstruction. So we didn't start in the subclinical phase, although we had an exploratory group looking at that, but rather looking at early disease to increase our likelihood of finding change. And so we had 178 patients that were enrolled in this study. The mean age was 23 years at baseline. 43% were under the age of 18. We had 39% that were female, and the mean left ventricular wall thickness was 17 millimeters. And it did look like valsartan had benefit in terms of preventing or improving adverse remodeling. So we can see here that in our overall composite Z-score, there was a positive change in valsartan and a negative change or relative worsening in the placebo arm. So overall, a net benefit for those on valsartan. And this held true across several pre-specified subgroups with similar results in males and females, and in those younger or older than 18 years of age, and across sarcomere gene, looking at myosin heavy chain and myosin binding protein C. We did see a significant difference based on baseline LV wall thickness with those with the less thick hearts, so less than the median left ventricular wall thickness, having more benefit. So again, suggesting that looking earlier or when there's less advanced remodeling might be more successful. So we concluded from VANISH that this, really intriguing test of a novel strategy of disease modification in early sarcomeric HCM. So we wanted to target early stage disease that would potentially be more responsive to pharmacologic intervention. We found that valsartan appeared to improve a composite outcome, which integrated 9 metrics reflecting cardiac remodeling. So the disease progression was stabilized or potentially improved with valsartan. And we saw the largest effects in improvement in NT-proBNP level and E prime velocity and in LV and diastolic volume. The treatment benefit appeared to be greatest in the individuals with the lesser amounts of hypertrophic remodeling, so less than the median. And so again, this highlights that disease-modifying therapy may be most effective if given early or when there's less pronounced remodeling. And it indicates that there's an opportunity to attenuate disease progression in sarcomeric HCM with a widely available and well-tolerated medication. Importantly, we did not and were not able to study its impacts on clinical outcomes that we and our patients care about more. Can this help prevent the onset of symptoms? Can it help prevent development of atrial fibrillation? Can it have other more clinically meaningful impact? That would require a trial of many hundreds of these individuals followed over decades. And that's a very hard trial to do. So right now we have a shared decision-making approach where we mention to our VANISH eligible patients in clinic the results of the study and try to help them understand if they would like to be proactive. There's little downside and little risk in this treatment. There might be benefit, or they're more along the lines of wanting to avoid medications. If there's not clear and more clinically impactful benefit. And so these cardiac myosin inhibitors may also have a role in attenuating disease progression. Again, in a mouse clinical trial, mavacamten was shown to decrease left ventricular hypertrophy and fibrosis in treated versus untreated mice. And so if safety can be very robustly demonstrated through the clinically available mavacamten or through the long-term extension of studies that are ongoing with both mavacamten and aficamten, it may be reasonable to think about moving forward with disease-modifying trials in younger, healthy subclinical variant carriers. And then also gene therapy is starting to become a reality in HCM and in other genetic heart disease. The gene therapy can come in several flavors. We can think about trying to silence the allele that has the gene mutation in a tissue-specific way with gene editing. There was also a proof of concept experiment that was done using CRISPR to correct zygotes that carried a myosin binding protein T mutation, in vitro. And then there are some models of HCM where instead of making a mutant protein, you don't make enough of the protein. That's what causes disease. And that's particularly the case in HCM caused by myosin binding protein C. So are there ways that we can try to do gene therapy where we use viral vectors to deliver a gene replacement? Or we can try to have the heart tissue itself be modified to produce more of a full-length protein product. So all of these are in the works, and maybe even in the next decade we'll be seeing these potentially be realized in the clinic. And there are clinical trials actually of gene replacement therapy for myosin binding protein C that are going to be starting phase 1 therapies within the calendar year or next year. And so looking to the future, we already are able to use myosin inhibitors as a very effective way to improve symptoms and feel and function in symptomatic outflow tract obstruction. Can they be used earlier in disease modification? We can think about using angiotensin receptor blockers also for disease modification and potentially gene therapy down the road. So in summary, HCM is often, but not always, caused by sarcomere gene variants. The hallmarks of disease are unexplained left ventricular hypertrophy, hypercontractility, myocardial fibrosis, and abnormal relaxation. Disease expression and natural history are highly variable, but the morphology, the age of onset, and even outcomes can be influenced by the underlying genetics, with worse outcomes seen in those with sarcomeric disease. And a better understanding of the molecular mechanisms of disease is helping to improve our management of families now and helping to guide the development of more specific disease relevant therapies in the future. So thank you very much.